So today mostly we're going to cover knee injuries that happen in athletes. We can, if some people are interested in some arthritic topics, we can get to those later if you like. But most of this is going to be focused on the vast majority of injuries that can happen throughout your athletic career. And when we say athletic career, it doesn't mean you have to be in high school or college or in a competitive sport. But even if you're a recreational athlete, I treat you as your collegiate, high school, or professional athlete. So before we can go any further, we really have to understand the anatomy of the knee so we know the parts we're talking about. When you look under the skin, these are the muscles that involve. The big take home here is these group of muscles right here. They're super important. It's the quads. So you have 4 muscles help the quad. There's one here, one here, one here, and one right underneath there. So there's 4 muscles that make up the quadriceps component, but you can see that this kneecap right here is tethered to this attachment right here on the tibial tubercle up through the patellar tendon, the patella, the quad tendon, into the quadriceps muscle. And so these play a huge role in keeping this kneecap centered into the groove. So from a muscle standpoint, that's the most important. Then we have the LCL, which is the lateral collateral ligament. Lateral means the outside of the knee. You have the MCL, which is the medial collateral ligament, which means the inside of the knee. And then you have the ACL, which everyone has pretty much heard of here. That's the big hot topic in sports medicine. And then the PCL is the ligament behind there. And then you have the 4 bones, which is the patella, which is the kneecap, the femur, which is your thigh bone that comes down, your tibia, which is your shin bone that comes up, and your fibula. Okay, then if we get down a little bit closer, we can see that there's still the ACL stump there, but then you have the meniscus. Here's the medial meniscus, and here's the lateral meniscus. You can see like they're little C-shaped discs that go between the knee. So you can see them, they're kind of little shock absorbers between the thigh bone and the shin bone. So there is a ton of injuries that can happen in the knee. This is only some of them. There's a ton more than this. So really, the ones we're going to hit today are the ones that are highlighted. If anybody, I mean, this is a small enough group. If you guys have questions along the way or want me to go a little bit deeper into something else, or you want me to talk about one of these injuries that's not highlighted, I'd be happy to just raise your hand or yell out, and we can talk about whatever you guys like. One of the most common ones, especially in females, especially in high school and college age, is this Patellofemoral Syndrome runner's knee. This makes up, if you tell me that you are a high school or college female and you didn't have an injury and you have knee pain, 90 out of 100 times, this is the cause of the pain. So there's other names for it. You know, people call it runner's knee. It's patellar maltracking syndrome, patellar friction syndrome, chondromalacia patella. What we're getting at here is just you are getting irritated by the way the kneecap rubs in the groove. And it sounds pretty simple, but this does not happen in an injury. You don't have to have an injury to have this happen. This can just be overuse. This can be you get a little hip pain, you could sprain your ankle, you start limping for a couple days, and then you end up developing an imbalance in the muscles which do not allow this kneecap to track properly, and you end up getting pain in the front of your knee. So the reason any little problem or any little degree of change of this patella into the groove matters is because of how much force goes across that joint. So if you sit with your leg straight and you just move your kneecap around, your kneecap moves all over the place. If you just bend it up a little bit, it locks in there. If your leg is straight, there's no pressure on it. As soon as you get to around 90 degrees, it puts 1 to 2 times your body weight from your kneecap into your thigh bone. Going up and down stairs 2 to 4 times your body weight. Squatting, kneeling 4 to 6 times your body weight, and up to 11 times if you run. So if every step you're taking during running is rubbing this into this and you do not have the appropriate mechanics, you're going to get pain. So why do you get this? Well, there's a couple reasons. The old school thinking was just the VMO, that it was just this little muscle in here that's not caught up, and that's the only reason. That needs to pull the kneecap in a little bit and you'll be fine. We've learned that's not quite the whole picture. The reason it happens more in females is because the females have something we call a Q angle, but really for childbirth reasons, just compared to your male counterpart, hips are slightly wider. Your hips are slightly wider. It means your femur will come in at a little bit sharper angle, which bring your knees in a little bit more. That increases that angle. So if we look and we see right here where the kneecap attaches to the tubercle, and then it doesn't attach way again until up here to the hip bone, and then you pull it on a string. If this knee is in more and you pull it on a string, it's going to force the kneecap out. And you're built that way. There's nothing you can do to overcome that. Bone structure, you need to work on the muscles to retrain the muscles. It's called runner's knee because if you don't cross-train and you just go out and run every day, you build up these muscles quite a bit, and these muscles get left behind a little bit, and then you develop this imbalance, and then that kneecap starts rubbing. You know, when you do get this, like we talked about, pain in the front of the knee, difficulty go up and down the stairs because it's putting a ton more force across the patellofemoral joint or that kneecap joint. And then it's not typically it can be a sharp stabbing pain if it gets bad enough where it jumps off the groove, but usually it's like a toothache type feeling in your knee. You know, your story's usually pretty good. The physical exam's usually pretty easy. You have pain right on the edge of the kneecap and all the other exams are negative. An x-ray is helpful because it allows us to see the tracking of the kneecap in the groove. We usually do not need an MRI for this. Usually an MRI is not super helpful for this. So the treatment for this, really, it's going to be your trainers or your therapist. That's the number one thing. It's not just going to be working on a VMO program. They're going to have to tailor it to you. So they're going to have to look at your hip motion. They're going to have to look at your low back. They're going to have to look at your abs. They're going to have to look at how strong your quads are versus your hamstrings and your calf muscle and get everything tuned up so everything's working properly to keep that kneecap tracked. Especially in the summer months, it's tough. Especially with the female athletes, you want to wear flip-flops, you want to go barefoot. If you have a little problem where you have a little bit of flat, your feet are a little flat, or we call it a valgus angulation in your feet, that's going to make this worse. So a little bit better to wear sneakers or something with good arch supports around the house or outside while this is going on. And then ice and anti-inflammatories, if needed. The ice is super helpful. Anti-inflammatories, usually in young athletes, we don't usually put you on a prolonged period of that. And then bracing can help in the short term, but the forces we're talking about, there's no neoprene brace that's going to hold your kneecap for like 6 to 8 times your body weight long enough. It can help a little bit while you're walking in the initial phases, but long-term bracing, not super helpful. And then rarely, if ever, surgery for this. Surgery for this gets into if you have a patella tracking problem that's severe. So if you have a grossly deformed knee or you have a chondral defect, which we'll get to a little bit, surgery has to do with tightening one side, loosening another, or breaking the bone and reshifting it to realign the kneecap. But hardly ever do we have, I'd say 99% of the time in this type of situation without extenuating circumstances do we ever get to surgery. So just to tie that together, that goes along with runner's knee is the IT band syndrome. This is super common, and this is male, female, all over the board. Usually this gets tied in because this is the side view of your hip right here. So you can see this band attaches all the way to the crest of your hip, all the way up here, and then it runs down past the outside. It's called the greater trochanter. That's what that GT is. That's the side bone of your hip here, and runs all the way down your leg and attaches to the outside of your knee. But you can see right here, there's a retinaculum that attaches to the kneecap right back to that IT band. See, right through here. So if you get this patellofemoral syndrome and it gets bad enough where these structures get really tight and are pulling the kneecap out of the side, that can make this tight, and vice versa. The big thing with that is just knowing, just because you have pain on the outside of your knee, doesn't have to be a meniscus tear, it doesn't have to be anything structural. It can be just this IT band that's tight. It can also give you pain up on the outside of your hip too. So in that case, it's important for your trainer or therapist to really work on just straightening this out. So a lot of stuff without an injury is just going to be trainer and therapy related. You just need to have the proper diagnosis so you know what to work on so you can get moving forward at a quicker pace. The problem is to stretch your IT band is very difficult. It's, you got to cross your leg, you got to pull it. Most people's upper body, almost nobody's upper body, is strong enough to overcome the muscles in your hip. There's stronger muscles than your upper body. So you physically cannot pull hard enough to make progress to stretch this out. Now you can maintain. So if your therapist or your trainer kind of gets you a little bit of progress, you can maintain that until the next time, until you go, but you can't really make progress in doing that. So the roller, what the roller does, it doesn't really work on the muscles, but it works on the band itself. So yeah, rollers are super helpful because you can put more force across it than you could with your upper body. But there's also techniques that some of the therapists and trainers have where they can do a Grafton technique, it's called, where they take little metal bars and do that. It hurts like heck, but it can be beneficial. Yeah, it can be beneficial with cases that don't respond to pure stretching. So when we talk about articular cartilage problems, we're talking about this cap at the end of the bones. So the cap at the end of the bones protect the bones, and they allow it to glide. So when you have good cartilage against good cartilage, there's no pain fibers in cartilage. So you just rub the cartilage and you're fine. When you have a problem with this cartilage cap, then you're close to the bone. You have exposed bone. And when you have exposed bone, bone has the pain fibers in it, and that's what hurts. There's no therapy or anything that you can do to fix this actual problem. This is a structural problem in your knee. And so the worry is that, so you're pretty much giving yourself arthritis immediately. That's what arthritis is the loss of this cartilage cap. Usually that's from a wearing down process. And then there's 3 things we'll talk about how you get this problem. One, chondromalacia just means you're beating up the cartilage, you're irritating it. That's the patellofemoral syndrome. That's a little softening, not a big deal. Then we have defects in the cartilage. You can either take it off with an injury or you can develop something called an osteochondritis dissecans, which is an OCD, which means the bone underneath, the cartilage is breaking off the bone, or the bone underneath is dying. So we'll go over each one of these. We already went over the patellofemoral. We'll start with the articular cartilage problems. So you're running, you feel a big pop in your knee swells up. Doesn't have to be an ACL. You could take a chunk of this cartilage off. So where it looks really nice here, you have a big hole where the cartilage is supposed to be. Now you have exposed bone. That exposed bone has a lot of pain fibers in it. Like when you break a bone, it really hurts. It hurts because there's a lot of pain fibers in it. Now you have exposed bone, and this can be painful. So you can break it off into one big piece, or it can fragment and break off into little pieces. So your knee will usually swell up huge. You'll have a ton of pain, and if that piece breaks off, you'll feel your knee getting stuck and get locked in place. So usually, you know, the story's pretty good. The physical exam makes us think we're worried. We can't really pinpoint this on physical exam because your knee's too painful and too swollen to move around. So we can't really, it's usually an MRI that does it. Now, an X-ray is helpful because sometimes when you take a piece of cartilage off, a sliver of bone will come. The younger you are, the more likely you are to take a sliver of bone with it. We can see that right away on X-ray. But you can see on the MRI, here's the thigh bone, here's the kneecap. You can see nice cartilage, nice cartilage, nice cartilage, and then boom, there's nothing here. This piece is gone. And that piece is floating around the knee, and if we look, here it is stuck behind the knee back there, wedged in there. So that's a problem. We don't want to leave these pieces floating around the knee because if they get caught, then they can do more damage. So the treatment for this, if it's really small, if it's just little pieces and fragments and they stick to the lining, your body will adhere them to them and resorb them over time. So if it's really small, we just ice you, rehab you, get you in a brace to protect it. If it's a large, though, that requires surgery, a large osteochondral fragment. The hope is if you get to it soon enough, you can take that piece and put it back in there and screw that back in, just as long as the screw heads are underneath the cartilage cap. You can put that back into place. If you don't get to it soon enough, then your body kind of resorbs this piece floating around and it doesn't really fit back in. So that's not an option to fix it. So we'll talk about other options down the road because it'll be the same options as the OCD, which is the next one. So this is the same thing, a problem with the cartilage, but you didn't have an injury to this. It's just your knee started bugging you, had swelling, you know, you're at the end of a season or mid-season, your knee's killing you and you don't know what happened. You can have pain only if the piece comes loose do you really get catching and locking, but there's usually pain and swelling associated with this. The history is usually what I just said. You have pain, you don't know what started. Physical exam will help rule out other things, but will not necessarily diagnose this. You can see this sometimes on X-ray. If we look here, if it's bad enough, it's a little subtle, but you can see that this is really smooth here, and you see a little divot in here. When we see that little divot on X-ray, that clues us in that we need to get an MRI. And then an MRI is plain as day. You see this big issue. The issue here is this bone is not doing well, and that cartilage is not adhering to that bone very well. So depends on where you're at in life, where the location is, the size of it, how deep it is, depends on what we do. If your growth plates are open and you're young enough, we try not to touch these at all. These can grow in and heal in and be perfectly normal at the end of your growth cycle. So we try not to touch them. If the growth plates are closed, they usually do not heal on their own and they need a little help. Now, if it's small and not painful, we don't worry about it. If it's in an area that's not weight bearing, like if it's in the way back when the only time it comes into contact is if you bend your knee up very far, then we may let it go a little bit. But other than that, it's surgery to fix that. Now, these are all different kinds of surgeries to fix this. We can go in and to make little poke holes. So the area's cleaned out, you stab it with a little pick, you make holes, the holes bleed, fill in with scar cartilage. You take little cartilage plugs from other parts of the knee that don't need it and put it in there in like a mosaic pattern. You can drill a hole, clean out that whole area, put a cadaver graft in there that matches, or we could take a little sheath from the lining of the bone somewhere else in the body, grow cells from a lab, inject it in, and try to regrow the cartilage. The reason I'm showing you all these are just some of the procedures that are good for a large lesion in the knee. If there's this many surgeries to do something, there's usually not one good surgery to do something. So the success rate for all these are about the same. Always start with a little most of the time, depending on the size. If it's smaller, we start with the poke holes. The larger, we may just jump to something like this. So we'll move on to the meniscus stuff. This stuff's super common. So the other stuff is a little bit more rare. This is really, really common. This is common in all ages, okay? So meniscal injury in a high school, college pro athlete is going to be a little bit different than somebody who's playing golf in their late 50s and get a meniscal tear. And the reason for that is how the meniscus is made up. So this meniscus, the younger we are, the stronger the meniscus is. As we get a little bit older, we lose the water content in the meniscus. So if I have a high school athlete running, a lot of times they'll feel a pop and they will get a lot of swelling in their knee and pain that'll come gradually. The older population, you don't have that water content, so you may not even feel a pop. You may not even think you had an injury. You're just walking along, something feels a little rough, and over time it tears a little bit bigger, and then you have a lot of pain from a meniscal injury, but you don't remember an exact trauma. So for the athletes, usually it's pain, swelling. If the tear is large enough and there's a little fragment that flips, it can catch, and it can feel like your knee's giving out. You kind of walk, you get that piece that stuck, your knee wants to buckle on you. History is usually pretty good. Usually the athletes that come and give a pretty good story that already, before I even lay my hands on them, make me think they have a meniscal tear. Physical exam's pretty good too. We can get pretty close with a physical exam. And then to actually diagnose the problem, an MRI is needed to know the type of tear, the location of the tear, and kind of guide the treatment versus operative versus non-operative treatment. But there's a ton of different kinds, and these aren't even all of them. I also meant, you can tear it right off of the root and flip the whole thing out, but these are a bunch of different kinds. Now, as an athlete, you treat them a little bit differently. You can see over here how they drew it in with the red on the outside and the white on the inside. They do that because the blood supply for the meniscus comes from the outside. So if you tear your meniscus and the meniscus tear is transverse, that has no ability to heal itself. So it doesn't matter if you're 15 or 70, you come in with this, we got to take that portion of the tear out. It can't heal itself, fixing it's a waste of time, so we get it out of there. If it's a peripheral tear, if it's near the edge, if you're 15, that blood supply is still pretty good. We try to fix this. If you're 75, there's no blood supply there anyway, that goes as well. Usually when you get out of your 20s, maybe 30s, depending on your activity level, we don't fix any of the meniscal tears, we just take them out. Bucket handle tears are the bad ones. They're the ones that tear all the way from the back to the front. This flips up like a bucket handle. That can get wedged in the middle of the knee, and they're the ones that actually get your knee stuck, or your knee's kind of stuck like this and you can't get straight. The sooner we get to this, the easier it is to fix it. If we get to it late, it won't be fixable, and then this whole piece comes out. In a younger athlete, we can fix this back to here. And in an older patient, without the blood supply, this comes out. So really, here's the two treatment. You can see there's a tear in the meniscus there. There's your thigh bone, there's your shin bone, there's a piece of that meniscus wedged in there. That can't be fixed. That's on the inside where there's no blood supply. So we just trim that out and leave good meniscus in there, take the torn fragment out. That's called a meniscectomy. That's what 90% of people get when they have a meniscal tear and we go to surgery. That's what happens. If you are one of those rare patients where you still have a good blood supply, the tear's near the outside, then we can fix it. And we just put these little instruments in. There's a ton of different types. This is one type where you go and block it and you just put the suture and you tack it back down. The idea is that you pin this defect in long enough so blood supply heals this again. So the discussion I have in the office all the time with my patients is this versus this, because my athletes all want this, their parents all want this. This is better long term, this is quicker return. Because if I don't fix anything, you're on crutches for a day or two, you're in physical therapy, and you're usually back on the field in 3 to 4 weeks, if everything goes perfectly. And you have trainers that, like my professional athletes get back in 3 to 4 weeks. My high school one's usually about 4 weeks. If I do this, you're on crutches for 4 to 6 weeks, then that rehab program starts. So you're about 3 months from getting back from this. But better long term, if you can keep it, this gets you back quicker. This, still, the failure rate of this is still pretty high. No matter how good of a job we do fixing this, it's still about a 60% success rate. All right, so now we'll move to the big topic. It's really ACL injuries. This is the one where everybody hangs their head, thinks their life's over when they have an ACL. It's only because of the time involved. It's not a super painful recovery. It's not, and the surgeries are really good now. A lot of the things we used to discuss, we don't even discuss anymore because we've kind of got it figured out. You can sprain at your ACL, which is not a big deal. It's just a couple weeks, maybe 3 weeks of rehab. Partial tears are pretty rare. We don't see those a lot. Now, some guys will call everything a partial tear if it's a sprain. Some radiologists will get a little bit antsy and call things partial tear, but it's very difficult. If your knee does enough motion to shift to tear some of the fibers, usually you tear all of them. So it's usually, in my experience, is either a sprain or a complete tear. Every once in a while I'll see one of these, but it's pretty rare. So you can see there's the ACL laying at us. The ACL comes at an angle this way. It also comes out at us. So the normal knee just kind of bends like this. It's a hinge joint, it just bends. Without an ACL, you can do some pivoting and some sliding. So your knee can do all these little tricks here. That's why the ACL is so important for knee stability. And most of those injuries, when you have them, they're not contact. It's not like somebody hits you in the knee. If I say, hey, you listen, you're playing field hockey or you're playing rugby and somebody comes in and clips you, usually not an ACL injury. If you said I was running down the field, I want to make a cut, and my knee just buckled, I went down and I couldn't keep playing, that's usually an ACL injury. So ACL tears are more common in females than males. Here's all the theories involved in this. Some of them I think are pretty good points. Some of them, I mean, the data is kind of throwing it out there. There's not really anything. But I'll tell you, I think the proprioceptive thing is a really important one. That's the one. Proprioceptive receptors are everywhere in your body. Allow to know where your hand is, where your knee is, where your foot is in space when you're walking. Females have less than those than males. So knowing where your knee is in space for different activities is super important, because if you're doing drills and your knee comes in a little bit more, that puts a ton more stress on your ACL. When I was at Cincinnati, we did this study where now it's commonplace, but you play these video games or see these video games where these guys look real life like they do through the game. That's because they put these suits on them. They can put these suits on and they just make them run and do moves, and then they can translate it into a video game. Well, we did this on a ton of male and female athletes in high school and made them do simple, just simple drills. And one of them was like a box jump. We just put them on a box jump. And we found that when males come down off the box jump, they land pretty square, which is advantageous for an ACL. When females land, they typically land with their knees in a little bit. When they do that, that's a poor function for the ACL. That actually can lead to more ACL tears. So a lot of these guys at this gym and stuff, what they do is start training on doing a lot of band work and things to make your hips stronger and to control your limb alignment a little bit better. Also, there's some proprioceptive receptors in the skin, so some females kind of put little knee sleeves on, which kind of add a little bit more proprioceptive. The hormonal factors kind of up in the air. The muscle strength thing, there's been people advocating this. The physical conditioning, really they're taking average, like across the board high school athletes. Once you get up to high level athletes, this is a wash, I think. Ligamentous laxity, that kind of goes along with the hormonal factor. Like estrogen in certain areas can cause some ligamentous laxity. Limb alignment's a huge one. So I think limb alignment, which goes along with this is anatomy. So I think anatomy is a huge thing, like notch width. You can see this wide notch, there's room for an ACL and PCL in there. And you see this real narrow one. The PCL dominates that. There's not a ton of room for the ACL, so that can be a factor. So there are reasons why this happens. I think the neuromuscular control, which goes a long way to say if we can prevent these injuries, way better than treating them after the fact. So symptoms we went over. You're going to usually feel a pop. You're going to go down. You're going to have swelling, instability. I do have patients that continue their game after an ACL tear. That's rare, but can happen. It's not unheard of. But usually the history, the physical exam's pretty darn good. If we get to you, if we get to you way late, maybe not, and if we get to you way early, it's really easy. But the physical exam's pretty good to be able to tell if you have an ACL. X-ray just helps us if there's a little bony flex or there's a translation issue, but MRI is really the answer for this. And you can see this pretty clearly on an MRI. I mean, there's the ACL, nice black line, looks perfect. We go here, black line, and then we see nothing right in there. So pretty easy to tell. MRI's pretty good with this. We can miss meniscal tears with MRIs sometimes. ACLs is pretty rare. So the treatment for ACL tears depends on the patient, okay? You do not have to have surgery for an ACL tear. It just depends on your activity level. The risk of not doing an ACL is that you can go on to some earlier arthritis and you can have a little bit more play in your knee like we talked about, which can lead to some meniscal tears in the future. If you told them, if patients come to me and absolutely are against surgery, it's okay. We can rehab you and get you strong, and you can get back to doing some things. If you're a straight ahead distance runner, not going to be an issue. Any cutting, pivoting sport, though, is tough. You're going to need most people need the ACL. There are some people, some rare people that are not ACL dominant and can get away without it, but that's few and far between. Most people aren't willing to wait the 4 months to rehab it to find out they're not and then get the surgery, and now it's over a year before they're back to sport. But I recommend in almost all my athletes to get their ACL reconstructed. And the reconstruction is just, we make a little hole in the bone here, make a little hole in the bone here, and then we slide a graft back up into the knee. This heals, gives it a blood supply, and then you have, over time, you have your own ACL again. Now we'll get into, you can we'll get into, these are what, you know, we can talk about in the office. When you have an ACL tear, you sit with your doctor and you sit and you talk about these things. Tunnel placement's been pretty much hammered out now. 10 years ago, we used to go to these meetings and talk about this all the time. Graft fixation, they all work now, not a big deal. The rehab protocols are all pretty darn close now. There's often just tailored, we tailor it more to the athlete now, so they're off a little bit, but they're all pretty much straightforward. The only thing that I spend time in my office now going over with my patients is the graft selection. This is the only thing that takes time to go over to pick the right graft for the right patient. This stuff's all going to be the same regardless. If you have a surgeon that knows what they're doing, this stuff's a non-issue. It's this stuff we have to have a talk. And the reason we have to have a talk is because there's not a clear-cut winner here. So if there's not a clear-cut winner, it's not like we say we're going to do this, we get some input from the patients. So two real main options, if I take it from you or I take it from a cadaver. And there's risks to benefits of each. And then there's risks and benefits of each one of these in between. How I usually look at this is if you are a younger athlete, if you're in high school or college or pros, and I have to get you back to an event, I almost always choose this. Only because it's a little bit more predictable about healing in a little bit quicker and I can get you back a little bit earlier. The cadaver grafts, once you're done with competitive sports and you're a recreational athlete, I go with the cadaver graft. If I tore my ACL tomorrow, I'm getting a cadaver graft now. I don't want to go through the increased pain, the larger incisions, the larger overtime, the harder out of the gate, just to give me maybe back to my sport maybe a month earlier. So the rehab for these things, it's really you're on crutches for a while, you're on brace. The braces are kind of up in the air. You have to use them early, but the question is late, do you need them or not? You got to get the swelling down, you got to get your motion back, you got the muscle firing again. Once the muscle's firing, you got to get the muscle not to weaken to the point where you're not protecting the graft. So this is the big deal. You're just really waiting for this graft to heal. Most people get the muscle back. Job of my patients is to get their muscles working by the time the graft heals. So if I lean more towards, I cut my patients loose usually around 6 months, depending on their muscle. If their muscles are not working or not firing like they should, we got to protect you a little bit longer so you would protect the graft a little bit. You notice I didn't put timelines on this whole thing because everybody's a little bit different. It really depends on how you're progressing. But usually everybody kind of agrees on a 6 to 9 months return to sports. But like I've kind of talked about throughout this whole thing, if we can prevent these things, it's way better. They're all pretty similar on how you prevent them. It's really having a good core, it's having great flexibility, and it's really having good body awareness. That's what the big thing is. So like training programs like Core Excel, or if you have personal trainers, or if you have a good sports therapist, doing preventative programs are invaluable. We've actually seen a decrease in the rate. The number going up because more people are getting into sports and sports are getting more competitive and a little bit high level, but the rate is actually dropping because of this preventative programs. Proper shoe wear depending on the surface you're playing on, but your core, where your hips are in space, where your knees are in space, are invaluable, and that's proprioceptive training and flexibility and muscle balance and strength training. The bracing thing, there's not a brace that is shown to prevent almost any of these injuries. The only bracing to prevent injuries that we have shown is in offensive linemen in football. If you wear the ACL braces, they prevent grade 3 MCL injuries. That's really, other than that, the preventative stuff, it doesn't really happen. So if you feel better with a brace or psychologically with feedback, it feels better, it's okay. If it doesn't slow you down, it's not going to hurt you, but you may not be preventing any injury. Now there is something to bracing, after injuries and after surgery. I usually recommend, I personally try to have my patients wear their ACL functional brace for about a year after the surgery, but if it really limits their function and how good their sport, we'll get them out of it. I'd rather you feel more comfortable and be better than slow and constantly thinking about this on the field. All right, thanks guys, I appreciate it.